Good afternoon. I want to welcome you all to our Penn LDI virtual seminar. I'm David Grandy, LDI's Director of Policy, and I'm pleased to welcome you all to this discussion today on access and payment for high-cost cell and gene therapies. I want to go ahead and introduce our excellent panel of experts today. The first is Stacy Dusetzina, who's a professor of health policy and the Ingram Professor of Cancer Research at Vanderbilt University Medical Center and current MedPAC commissioner. And her work focuses on policy changes that might improve patient access to high-priced drugs. So thank you, Stacy, for joining us. Next is Titalope Fasipe. Titalope is an assistant professor of pediatrics at Baylor College of Medicine and co-director of the Sickle Cell Program, and she also serves on NIH's Sickle Cell Disease Advisory Committee. So thank you, Titalope, for joining us. Next up is Jared Henshaw. Jared is the recently retired CEO of Synergy, a medication contracting organization founded by a group of Blue Cross and Blue Shield affiliated companies to improve affordability and access to costly medical benefit drugs. And lastly is Aaron Kesselheim, professor of medicine at Harvard Medical School, where he created and leads the interdisciplinary program on regulation, therapeutics, and law, also known as Portal. Before I ask our panelists our first question of the day, I do want to set the stage briefly. So this is a topic that I think brings with it some really important policy questions, but there's a little bit of perhaps technologic and clinical background that is useful for setting the stage for the conversation today. And I think most people have probably joined this call because they know that cell and gene therapy has created new opportunities for truly breakthrough curative therapies for a range of conditions. The challenge, of course, is the very high costs and that the costs are upfront despite the lifelong benefits. It's not the first time the United States is experiencing the arrival of a high-cost breakthrough therapy. For example, we had similar debates when hepatitis C therapy arrived. However, the cost of these breakthrough therapies is now going up and up and up, and now we're in the millions. But what is cell and gene therapy? You hear the term thrown around a lot, but so before we jump into the economic challenges, I will attempt to give my general internal medicine 2-minute version of what kind of technology we're talking about today. A common thread across these different types of gene therapy is the idea of manipulating DNA or cells in some fashion to treat either a genetic condition or a condition like cancer. This can be done in the body or outside of the body. And for gene therapy, the goal may be to add, alter, or silence a gene. So you may hear terms such as gene therapy or gene editing to describe some of these approaches. And there are different ways to introduce genetic material into living cells, and some of the challenge of the technology is identifying the best way to deliver the genetic material in a way that is both safe and effective. For cell therapy, the goal is to modify cells to alter their function in the body. For example, CAR T cell therapy is used to treat certain forms of cancer. But the bottom line in all of this is that the treatments are quite expensive. The care that's required can be complex, but these therapies have the potential to cure previously incurable conditions. And so that is what brings us to the importance of this conversation today, is to try to tackle issues around access and payment. So I do want to ask Stacy if you could get us started with a bit of a level set on the unique economic challenges of cell and gene therapy, and perhaps spend a few minutes discussing the types of conditions they treat and what the pricing, coverage, and utilization have looked like since the first FDA approvals.
And thank you for that internal medicine overview of cell and gene therapy. I find it to be really helpful as someone who comes at this as a social scientist rather than as a clinician. Cell and gene therapies are super exciting, I think, for the field. And when we think about innovative treatments, it's the type of products we really want to have access to because they seem to have such high benefits for patient populations that have not had really reasonable treatment options. To date, a lot of the development has been in the area of blood disorders, and some of the earliest cell and gene therapies were in blood cancers in particular. We've seen that evolve over the recent years and have seen some real breakthroughs for rare conditions, beta thalassemia. We also have some for more common conditions, relatively speaking, sickle cell, hemophilia. And then there are some others that are in the mix things like inherited blindness. But again, a lot of these target fairly small patient populations in rare diseases, but not all of them. As far as the way things have worked from an economics perspective, there are a couple of key problems in our system that have made these hard to access for patients and hard to manage for payers. One is pricing and pricing models. So CAR T is a good example, one of the first cell therapies available. And the pricing for that was $373,000 for an adult with lymphoma. When that first came out, there were a lot of concerns about access because of the way that Medicare payment was set for CAR T, which in some cases would not be enough to cover the amount that a hospital would spend while delivering the therapy. Even on the commercial market and for the VA and for other payers, there were things like single case agreements being negotiated with hospitals to even define like who could get access and who could get an agreed upon payment. So the access to the therapy, while we could figure out who clinically might be able to benefit from it, figuring out who was going to pay for it and how those payments would look was a little bit one-off. I think that that's been several years now and that there has been progress on getting access to those therapies, but the prices have also gone up dramatically since that time. So now we're talking about products entering the market at $2, $3, $4 million per patient treated, and that creates additional stressors. One other thing I think is important to put into context is the fragmentation of our payer system and how that doesn't help us here. So a lot of therapies, some of the earlier ones were predominantly Medicare as one of the payers with treatment for lymphoma, as I mentioned. But we also now have a lot of products that target people who are covered by the Medicaid programs. And those programs don't have flexibility in their budgets to be able to overrun their spending targets for the year. So when we think about making these drugs accessible, price tags of $2 or $3 million per person treated becomes a real budget constraint. So there are absolutely some significant challenges and partly the fragmentation of our system and who pays and then who gets the long-term benefits of someone having been treated come up as a big sticking point.
Thanks for that opening, Stacey, and very helpful. And a lot of what you said, I think we'll need to come back to. But I want to move on to Titalope. Stacey just gave us that macro view. Can you help us zoom in on a specific condition and set of therapies? So there's been a lot of attention recently to sickle cell treatment, which is a condition that overwhelmingly impacts Black Americans. Can you help us understand better what it looks like from the ground level for patients and what's actually involved in administering treatment? And what are some of the factors that affect access to new sickle cell treatments, whether it be coverage rules, provider supply, or the patient's own decision-making?
Thank you. And apologies for my hoarseness of the voice. I feel fine. So, and thank you also for this opportunity. I am very happy to be here to be on this panel. So I wanted to start off where you left us with the question of bringing it down to a disease level and what does it look like for the individual person and what that is, what it looks like for what it means to a patient. So thalassemia's gene therapy product was approved 2 years, about a year and a half before the sickle cell product, but because it was in the same family, if you will, we already were excited and patients with sickle cell disease already knew about the concept of gene therapy for sickle cell, some partly because of the thalassemia experience and partly because there was a lot more engagement in the clinical trials that were existing for gene therapy. Gene therapy for sickle cell is a transplant-based therapy. And we knew since the mid-'80s that you could use transplant, stem cell transplant, to potentially cure sickle cell disease. However, that required a donor. The gene therapy products that we're talking about for sickle cell and thalassemia both involve manipulating and updating or fixing editing the stem cells prior to giving them back to the patient. And so they are their own donor. And so because it is a transplant-based therapy, the same healthcare utilization associated with transplant overlaps into the space of gene therapy for sickle cell. So from beginning to end, it looks like a person saying that they are interested in gene therapy and meeting not just a hematologist, but a transplant doctor who's also in the hemonc world. And then if everything goes well with their pre-transplant screening and processing, then that's a several-month process. The cells are collected, and then that is also another time process to make the cells, manufacture them. And then when it is time to deliver the therapy, the patient is admitted into the hospital, given a course of chemotherapy, and then for conditioning, and then given the new stem cells. And in that period, they stay in the hospital for about a month to 2 months. And that's if, in the best case scenario, there's no complications. And once they are out of the hospital, they then have frequent visits to make sure that things are going well with those stem cells. And so this is a pause. I tell families that they're pausing their life for 1 year to 2 years to get this therapy. Now, our best experience is, of course, those that were brave enough to participate in the clinical trial. So those families were the ones that taught us about what it looked like. When thalassemia's gene therapy became approved, I learned quickly that we'd have to be careful with the news media reports and then the reality of when people can actually get it. The moment that it was approved was not the moment individuals were getting gene therapy right off the bat. There were several conversations that I think some of the people on this call are more adept to answer, but several conversations with payers and it really was this line between, if you are in the commercial space, you are more likely to be considered, and we did have to have different conversations when it came to public payer mechanisms. And so that's what happened. And so I realized that was going to be the same thing with sickle cell disease. The sickle cell gene therapies, 2 of them were approved in December 2023, and we had very similar conversations. We could have an interest list, but nobody could actually get it until we knew what the coverage and what the payment model was going to be. And that involved our institution working it out with the companies that make the gene therapies, as well as with our various commercial payers, understanding their plans and what they considered eligibility. And so right now, even though the therapies were approved in late 2023, we are just now evaluating children to get the treatment, and those are children who do have a commercial payer. For our Medicaid, our patients who are Medicaid beneficiaries, we were excited to hear about the CMS innovation model system and the cell and gene therapy access model. However, that did present the fact that we were going to have to wait until we understand more and what our state will do. So you are hearing the access challenges, and I've now collated, I'll summarize them, but one is you do need a treatment center, and they're not everywhere in the United States. I happen to be working at a center that's considered a qualified treatment center. And so if you're thinking about crossing states to get care, that also will present a problem. 2, you're putting somebody's life on pause and their family's life. And so the economic cost and the hidden cost of healthcare, where parents are taking off work and all that kind of stuff, people taking time off of school, vocational, educational, all of that. 3, in the perfect scenario, when everything goes right, you have a price tag, but then if there's complications, there's also additional costs to care for those. And then that last part, the part that I see is our ethical conundrum, which exists in all layers of healthcare. your payer sometimes does determine your access to care. So I think I'll stop there, and we can continue the conversation.
Yeah, those are that's a really great review, I think. I think a lot of people talk about these therapies in the policy context and don't realize the complex care that is involved here and what the life impact is. Obviously, there's a huge amount of benefit, but going through these treatments is a pretty big deal. So thank you for walking through that. And I think, again, many of the things you touched on, I'd love to circle back on. But let's move on to you, Aaron. So the prices have been mentioned a couple times so far, and in this conversation, we might start by accepting that these high prices are a given. But in your work, you've raised the question about whether these prices are in fact inevitable. Can you first help us understand what goes into the prices we see today in the market, and then explain why you think that this inevitability of these prices is worth re-examining?
Sure. So first off, thanks for inviting me to be part of this group. It's been really educational so far. But basically, the general principle in the United States is that prices are what the drug companies say they are. Like we don't really have a system in the U.S. for coming around to what a price of a treatment or product should be in the pharmaceutical space. We let drug companies set whatever price they think that they can get away with in the market. And as a result, the prices for brand name drugs and treatments in the U.S. is 2 to 3 times higher than it is in other high-income countries around the world. And we spend, upwards of 15 to 20% of healthcare dollars on prescription drugs alone. And most of that is from very expensive products like these. And, in some cases, the products might be worth it because they're very effective and curative, in fact. And I think that word curative is thrown around a lot in the space of cell and gene therapies, when in fact there is a wide variety of efficacy for cell and gene therapy treatments. And just because something is a gene therapy doesn't necessarily mean it's curative, in that people may still need additional treatments on top of it. For many cases, a lot of these therapies come to market and we don't know how long the therapy, the effectiveness that we even observe in the clinical trial will last. And so people may need retreatments at some point in the future. I think that it is worth, it seems to me that a lot, in many cases with the cell and gene therapies, the idea is that, okay, well, it costs $4 million. Let's figure out how to pay for that. When I really think what we should be thinking first is, should it really cost $4 million in the first place? First of all, because we may not know how well the product works. And second of all, because in a lot of cases, these treatments originate from publicly funded sources, where the NIH and taxpayer funds go into developing these treatments through a lot of the riskiest early stage parts of the treatment, and the drug companies that are making the products available come in relatively late in the process. And so, is it necessarily the case that this price is necessarily is necessarily the right price for these products? So I think that those are some of the things that we need to think about when we're thinking about these. And of course, if there is a product that needs to have a high price, so Stacy mentioned the cell and gene therapies, or the cell therapies, and you heard from Delope about the complexity and the amount of work it takes to treat a person with these therapies. And in those cases, it might actually be the case that a high price is necessary to account for all of those features. And then we should figure out how to, if it is a treatment we need, then we need to figure out how to make that available to patients. But I think before we get there, we should take a step back and ask ourselves, what is a fair price, and how do we get there?
So, Jared, moving on to you, Synergy was created for insurance companies to try to navigate some of these high costs that we're discussing today. Can you talk about the challenges that led to the development of the company and how the organization tried to address those challenges, or is trying to address those challenges?
So Synergy was founded approximately 2 years ago. I was involved in that launch, led the launch of the company. And the main concept we're trying to kind of get at here is, if you think about our kind of environment today, is that there's a lot of scrutiny on the current system, especially with PBMs, the distortions in the payer markets and how those work. At the same time, scale, size absolutely matters to manage the best prices with pharmaceutical manufacturers, with health systems. So scale matters, data matters, geography matters. And so the Blues are perfectly positioned really to come together to align their lives. They have over 100 million medical lives. And if you think about their footprint, it's the entire United States. And looking at their data, they have the biggest data repository in the United States. And so the concept behind Synergy was to take all of those assets and to create a company where we could seek to solve some of the toughest challenges in the United States in a very, what I call, pure way, without those distortions that currently exist in the PBM market. So we started out focusing on drugs covered under the medical benefit. And one of the first things that we wanted to really focus on was cell and gene therapies. For all the reasons everyone's articulated, it really is an area where the payer system's not currently equipped to deal with it, both short-term and long-term. And really take a step back and assess what are the 2 or 3 big things, and this is really just in the commercial markets, that are kind of broken that we could seek to fix. And so we went about creating a portfolio, cell and gene payer solutions portfolio, to really fix those 2 or 3 issues, and built those products last year, launched them into the Blues market. There are currently over 100 million lives collectively enrolled in all 3 of those product portfolios. And they're really quite simple. I'll just kind of break them down really quickly. The first solution set really deals with the manufacturer and this notion of what is fair value, this concept of paying millions of dollars for upfront for a therapy with the promise of either curative or durability, right? Is that fair, right? What should the obligation of the manufacturer be if the drug doesn't work, right? And so the basic concept is, if the drug doesn't work, in my opinion, the manufacturer should be on the hook for some or all of that. And in today's markets, value-based care contracts, I think, quite frankly, are worthless. I've dealt with them for years, and that promise and commitment to refund money when a drug doesn't work really doesn't exist in those contracts for a number of reasons. So we wanted to really create a portfolio for the first time that creates that construct that is equitable for the payers and for manufacturers. The second is the concept of thinking about how to actually finance these types of therapies if you're a small self-funded employer and you unexpectedly get hit with one of these price tags. In today's market, stop loss insurance, most types of insurance really don't cover a lot of these therapies. And so it can be catastrophic for an employer to get hit with one of these. So we created what we call a national risk pool across the 100. It actually has about 10 million lives in it today, to spread that risk and allow small self-funded employers to be able to pay a very small amount to participate in this fund. And so if they happen to have a cell or gene therapy, then the risk pool bears the expense of that. And that's been very effective. And by the way, that's the largest risk pool in the United States to date. There are a number of them trying to be built. And then the third problem we were going after is this concept someone mentioned of, this is a national issue in terms of where you get the best care. Not every state has these qualified centers, and for certain drugs, there are certain centers that are qualified. And so thinking about how you connect that patient across the United States to the best care center, and importantly, at a fair and reasonable price, because it's not only the drug that's being reimbursed, but all of the administrative costs, which are quite expensive. So,
thanks, Jared. That's a really helpful summary. Interesting. I didn't realize that the current stop loss market wasn't really covering these. So this is really stepping into that space for self-funded employers, it sounds like, in a different...
Yeah, there's a concept in stop loss called lasering. If you have a known condition, then it doesn't cover the therapy. And so if you think of hemophilia, sickle cell. These are all known conditions. So the gene therapies that are emerging, most of them are lasered out under existing stop-loss policies. So there's a huge gap in the market today and a huge need to fill that void.
So this uncertainty around durability, Aaron, you brought it up, Jared, you just brought it up. This idea of the warranty, does that like what are the strengths and weaknesses of thinking about that in the pricing of these things? And do we think warranties remove some of that uncertainty that may come down the pike?
I've dealt a lot with warranties. So warranties are interesting. They're an interesting vehicle in the commercial markets to get essentially manufacturers to reimburse more than they otherwise would under what's called a rebate contract. But stepping back and thinking about the gaps, David, I don't think warranties in and of themselves are the solution. It's really in my opinion, there were two things wrong with value-based care contracts. One was in this space, thinking about, okay, if the drug doesn't work, the manufacturer should refund some of that money. So how do you define value? And so for gene therapies, the way I think about them, if you're paying $4 million up front, there should be hard cost offsets down the road, right? So with hemophilia, it's a lot easier. You have less factor used. And so you can kind of think about that trade-off as a payer, that it makes sense to cover them because you're going to have savings down the road, right? That's not the case with some of these. Like I think sickle cell, it's more difficult. But really the elephant in the room with manufacturers, they don't want to sign up for typically meaningful value-based care refunds, because if you think it just hurts their bottom line. And so the trick is getting them to sign up for meaningful refunds based on the right endpoint measurements with, I think, hard cost offsets where you can get them, because otherwise it's fairly illusory in terms of the value. The second is being able to track a patient over a long duration of time. These patients will move across commercial segments from commercial into Medicaid. And I think someone mentioned is who gets the benefit of this, right? If that endpoint fails in 3 years and the patient's moved on, how do you track it and refund the original payer? So in the solution sets I talked about, we actually created longitudinal tracking over multiple years across segments and even into Medicaid to help solve for that. That's absolutely critical. Otherwise, the payer, isn't refunded properly. So,
I would I would agree with all of that. And I would say, just to even go a step further, that the best solution would actually be to pay less upfront, rather than to pay it all upfront and then to keep chasing your tail to try to get the money back in cases where it doesn't work or isn't durable. But actually to try to sort of factor that the uncertainty around the durability into the upfront cost. And then I think that a better solution would be to provide, rather than providing all the money up front and trying to claw it back, providing a small amount of money up front and then providing continued small amounts of money if the durability does happen to meet what we expect. That seems to me to be most fair from a payer's point of view.
And I just want to add to that point that Aaron just made. One of the things that I also feel that's an attractive model, like amortize the payment over time as long as it keeps working, then you keep getting paid. But I have heard, for example, from states that type of model is higher risk for them. So it is a little bit of a sticking point, I think, depending on how you have to think about your budgeting. And while conceptually I'm completely on the same page with that model relative to the pay more upfront and get a refund later, it does come up as a sticking point for some groups when thinking about how to make these purchases.
And I'm curious about, I would love to learn more about the concept of how you put the durability and the reliability of the treatment into the factor. So one of it's my understanding that the current contracts between payers and the gene therapy companies for the sickle cell disease products and the thalassemia ones do include some kind of rebate value-based discussion. And I'm not expert on the intricacies of that, but there is if this doesn't work, you get your money back kind of guarantee. However, it's not the nuance that you're describing of the gradual payments. part of, I want to just clear up something with sickle cell and thalassemia. Because we know transplants work, they're quite effective at getting rid of the problem. I think that's why the gene therapies for sickle cell, you almost get like a 99%, 90, is such a high effect that you expect, which is why the companies, I think, even were comfortable doing a sure, we can do a rebate plan. And when you talked about the difficulties of understanding what does it mean to decrease cost in sickle cell, each person with sickle cell is not guaranteed the same number of complications. But when you aggregate the data of how much it costs the healthcare system, it's in the $800 million range, right? For inpatient stays. This was from 2016 report. $800 million a year to take care of people who are sick in the hospital with sickle cell disease related complications. And so, and I don't know how much you know about the cost models that have been done for gene therapy specifically for sickle cell, but most of them are using those kind of extrapolations and figuring that into what does it mean to have a payment? What does it mean to assign value to how much a payment should cost? So I'm curious with hemophilia and some of the others, like you said, over time you can see less factor. With something like sickle cell, where you expect the transplant to work, would you say that you would have a shorter time period, or you still think it should be over multiple years? And then to the point that Stacy made about some of the upfront cost of that hospitalization of making the product, how would that come into play?
That seems
And I
there.
guess that's to Jared.
Yeah, there are two factors there, right? There's the uncertainty of durability, and you're making the point in sickle cell that we perhaps have greater certainty. And then there's the separate issue of accruing the benefits over time. And so both of those have time horizon challenges associated with them. So, Jared, I don't know if you want to jump in.
And I'm not a clinician, so forgive me. I'll speak kind of in layman's terms here. But when I think about sickle cell, like looking at the ICER reports, I'm sure you're all familiar with ICER. You read all of that. Thinking about kind of the difficulty they had in kind of assigning kind of a clear trade-off between pay, X million up front, and this is kind of the correlation of reduced cost because it is different by patient, to your point, even though everyone probably understands there are tremendous financial benefits. But it seems to me, and I've dealt with the manufacturers in this space as well, getting people to identify what those cost offsets should be and over what duration and signing up for those on a consistent basis on an aggregate scale has been very challenging in sickle cell. It's been easier for certain other gene therapies. That's just been my experience. And I think that's really where the real trick is, to ascribe the right value and to make sure that it's very specific in terms of those cost offsets that have to be achieved over a certain duration. Otherwise, the refund should occur, or if you flipped it, as was suggested, so you pay less up front, that it's working appropriately. Because what typically happens in these deals is things are broadly defined or loosely defined, and the payouts don't occur. They just don't. So that's kind of that was the genesis for my remark.
Yeah, no, I
Makes
completely
sense.
understand. And I think I have to go back to something that Aaron said earlier. I see there's a lot of trouble with how drugs are manufactured in this country and how we assign cost. And I understand investors and profits and all of those things. But I just have to emphasize that the system that ICER and other health economists have created are still designed from the space of a broken system of how we even price drugs to begin with. You are basically trying to add value to a person's a sign of value or a number, a dollar sign to a person's life, and by using something called a quality, right? Something called a quality of life year or whatnot, and it's quite problematic. Part of the difficulty with sickle cell disease comes from the space of disparity. It comes from a space of disparity, right? And so I think this is a disease that it's a difficult disease for many reasons. but it's not because there's something wrong with the disease. There's something wrong with our system, if that makes sense. I think other conditions have a track record of other products associated with them. Sickle cell disease, I can count it on one hand how many products are available for a disease that, you know, has been, it's been a long-standing one. So I think that disparity is and equity is something that you can't capture in ICER quite well. They appreciated this and they actually had to revise some of their approaches. And you'll notice in some of the other models that are done to look at the concept of value, they're being more thoughtful about that impact of the inequities that have long challenged this disease space as well. So anyway, I'm fascinated by your work, and I hope that it will help make things closer to what is the right way to do it
So
mean, because
so
right now it's not working.
you hit the nail on the head for me. I've always struggled with like I mean I always look to what right looks like, what's the right value, what's the North Star for defining that. And you just articulate there really is no North Star today. I think that's a huge issue, certainly in the payer markets, right? That doesn't exist in the United States today. A lot of people look at ICER as the gold standard, but it's not there yet. I agree.
So, I think you're all, pointing to some just fundamental challenges around where we're at today and where we want to be in the future in terms of access. Are there ways that this all needs to look completely different? There are some that have argued this, that maybe there needs to be a Medicare Part E where, the public sector comes in and assumes this role entirely for these types of therapies. Obviously, that involves moving a lot of things onto public budgets that aren't currently. But I'm curious, as you think about this conversation we're having today and what access looks like, and what will naturally happen in many cases is there'll be these huge inequities that occur over time, some of which may be attributable to some of what Titalope described, which is like, what are all the challenges with even being able to be in this situation to receive this treatment, put your life on hold, and all of those aspects, but then also these differences by payer and who's paying and who's not paying. So I know that's a very big question, but what are your thoughts on some who have argued that this needs to move out of the current model of insurance altogether?
I am a big fan of thinking about really disrupting the way we pay for these types of therapies. And I think in earlier comments from the other panelists, you could kind of hear this. Who's getting it now? People who are the wealthier people in our country, probably healthy enough to get it and still leave some profit margin for the hospitals and systems who provide it. People on commercial health plans. So I think the way we've set things up to date will drive more inequity. So despite the fact that we have therapies that should disproportionately benefit Black individuals, so people with sickle cell disease, that should improve like our situation on health inequities if everybody had equal access, but we know they don't. So I think that it's time for a serious disruption. As mentioned in my initial comments, the fragmentation of payers is a critical problem here, and we need as much size as possible for negotiations. So if you had a single payer for cell and gene therapy that decided what the right payment was, we could get, both maybe better access for companies to know that once they agreed on a price, they had an entire patient population who could receive it. And it wouldn't be these single case agreements. You're lucky if your payer happens to be one of these plans who has negotiated with a hospital. I think we have to kind of throw out the current model if we're going to get these things really accessible to all people in our country.
I would say that I too would throw a party for a Medicare Part D. And I think that one of the benefits of it would also be that in addition, like I think that it would be better if something was set up like that, that it not mirror what we have right now in Part B, for example, where Medicare just pays whatever the average sales price is for a drug in the market, but instead we would have to also build a program that would evaluate the clinical benefits that drug provides or that treatments provide. In this case, if it was just a section of Medicare that would cover cell and gene therapies, then you'd be able to marry that coverage with an evaluation of the actual utility of the product and a determination of what a fair price should be, taking into account a lot of the things that a lot of the other panelists have mentioned today.
We know that virtually nothing in healthcare follows the rules of competitive markets, but I'm wondering if one were to look further out toward the future, would we expect these therapies to ever get cheaper? There's biosimilar markets that have struggled to emerge in biologics. Is there any hope that either on the manufacturing side, and this is one of the questions that came in the Q&A, that the manufacturing costs would go down, that anything here would put downward pressure on prices in a market-based system?
That is my prayer. I hope. Please go ahead, Stacey.
I think I'm a little bit skeptical of it. And maybe part of it is around products where the durability might not be as solid as what is seen in sickle cell or what is expected for sickle cell, because what we'll probably see is the next latest and greatest version. So we don't get to a place where anything gets cheaper, like over time, or we don't end up having kind of efficient generic entry. One of the other complicating factors that we haven't touched on as much here is that in some cases, these are more based on like hospital payments and hospital profits as well. And so, we think about those amounts of money that have been set aside or decided as like the amount you get paid for a case, or you get a markup over the price of the drug. So I think that without a significant disruption in who's paying for it and having more control over pricing from the payer side, that it's going to be hard to get any price relief here anytime soon.
So there's another question that I want to bring into the conversation here. Somebody who indicated they're the CEO of a gene therapy company. And what they're noting is that in the current market conditions, there's a near complete inability to raise money actually for cell and gene therapy. And so any suggestion that a company can't get the full price up front or reduce the price is a non-starter. VCs will just stop investing in CGT companies, full stop, and then patients will be left behind. So I'm curious, that different view, right? That there's trade-offs, of course, and this comes up in every conversation, right? About whether we're talking about cell and gene therapy or more traditional pharmaceuticals, is the trade-off between margins and innovation and investors versus access and prices. And so this is a more, can we call this an early industry? I don't know. But are there legitimate concerns here from your perspective that will choke off the research and development pipeline here?
All right, it took us 45 minutes to get to the all innovation will stop boogeyman. That you're right, that does come up in every conversation. And yes, if we try to make prices a little bit more fair, try to increase the ability for patients to access, try to make it a little bit more equitable across the board, the immediate response, of course, is that, all innovation will stop and we're never going to get any gene therapies. And I think that that's a troublesome argument because it sort of puts it kind of blocks any further conversation or discussion in this area to try to find a solution that both ensures that there is adequate compensation for investment and fair and reasonable revenues for for-profit companies that are involved here, but also fair prices for patients and the healthcare system. And I think currently we're not there, but I think we can get there if we do have conversations, fair and legitimate conversations, without continuing to fall back on this boogeyman, in which we try to understand how it can work for everybody, given the importance of these diseases and the importance of the science in this area, and the the available wealth that exists in countries like the United States and other places to devote to these kinds of situations, and all the public funding that goes into it up front. So yeah, not a surprising question.
I'll jump in there as well. Yeah, it is very common comment in this type of discussion. I would say what I hear a lot as well is, like, if you think about the unique nature of the gene therapies, they're dealing with very small patient populations, long R&D time. And so there's always a worry on the part of the manufacturer, will they capture most of that projected patient population or not, right? Because it's very small. And a lot of these companies are startups, not all of them, and so if you think about, I wasn't going to hit on it earlier, but I hit on it now, this concept of flipping value-based care on its head and just paying for a very small portion up front. If you think about the realistic economics of that, it probably doesn't work, because health systems have to buy this drug today. It's super expensive. They have to get reimbursed, right? And so if the payer's is not going to reimburse most of it today, it's essentially the manufacturer financing that deferred payment. And I don't think a lot of these small companies probably have the wherewithal to do it, or certainly it would tamp down on some investment, because that would be material. So I think we've got to find ways to solve for that. But I also think there's room for downward movement on price. And it's not just with the manufacturer, but I think it's the health systems as well. And it's not just the drug, it's also the administrative cost. So I think that it's that very difficult equilibrium we're striving for here, just in my opinion.
Titalope, I want to come back to you because you raised some important issues that I think are hidden from view in these conversations that happen more publicly, which you talked about what families have to go through in order to access these therapies. And what other things do we need to think about to create equity and access other than payment of the treatment itself? Because if all we do is pay for the treatment, it seems from what you described, there will be many individuals who say, I can't afford to put my life on pause.
Thank you so much. First, I have to say I'm grateful that you all exist, because this is when I entered medicine, I think most doctors are like, oh, I want to take care of patients. And it wasn't until I started practicing that I realized that taking care of patients also means, what is health policy? What are our cost structures? What are payer models? And it's been blowing my mind. So I have learned a lot today, and I'm just so grateful that you guys have invested your careers in this space. So I first wanted to say that. So our Medicaid medical director's office in our state once asked, they were scared of gene therapy being approved, because they were like, oh my gosh, is every person with sickle cell going to knock on their door and say that they want the gene therapy today? And I was like, no, that's not going to happen. For sickle cell specifically, access to basic care is a problem. Talk less of fancy care. So I think understanding what it means to comprehensively care for a disease, giving high quality care. So any kind of chronic disease, are you getting even your best preventive care to make you as healthy as possible? That is a problem that already exists in sickle cell. So it's ironic that we have gene therapy. We have one of the fanciest tools today. And yet, if you try to look at how many adults are getting care in this country from a person who knows how to treat them, it's not many. So there's not going to be a stampede to gene therapy just because of that first access to care component. And then we do have the concern that when you do have a rare disease, or a disease that does not have that many treatments afforded to it, whenever something is in clinical trials or does come out, the fanfare associated with it is often followed by that letdown of reality, to the points that were already raised today. And I learned this because in 2017 and 2019, sickle cell had only one treatment up until 2017, one drug, hydroxyurea. So 2017 and 2019, other drugs that are not gene therapies were approved. And there was a gap to even getting those to patients. And so there's this I had called it the water everywhere, but not a drop to drink concept where you are telling me that there's something there, but I can't really apply it to my life or to my patients' lives. And so I might as well be sitting in an ocean, right? And not drinking water at all. So I hope that didn't sound too dark, but I think one of the components that I want folks to realize is that the other component about Medicaid and Medicare is that it's not truly a universal approach, right? So Medicare is federally based, but Medicaid is a state action. And so if you're in a state that does not have Medicaid expansion for adults with chronic illnesses, most children in my state with sickle cell disease will lose their Medicaid at the age of 19, most of them, even though they have a chronic illness. And so care should not just be in your pediatric phase. You need to have a lifespan approach when it comes to a disease, and that incorporates all the basic stuff. It's not just the fancy stuff. I want to make sure I'm addressing your question appropriately. Was there an aspect there that I haven't yet covered?
Yeah, I guess what I'm thinking about is, we're thinking about paying for the clinical costs of
Mhm.
administering treatment. We're thinking about paying the manufacturer for the price of this technology. But people have to not work potentially for a
Exactly.
month or two. And there's some who can afford that and some who can't. And
Exactly. To Stacy's points about who is actually going to get this therapy, who has the luxury to take time off of work. Um, there were some other hidden costs that I didn't address earlier, but there's an impact. I mentioned chemotherapy, but fertility preservation is another cost that for cancer, sometimes you'll find foundational grants or people who are like, oh, we're going to pay for your fertility preservation because you're going to undergo a therapy that might impact your ability to have a family. And so those are things that need to be wrapped into the conversation. What is the comprehensive, holistic view of looking at an individual when they're doing a high risk therapy that also has some other hidden cost associated to it? So you will see families make that decision. If they don't have a job that is a remote only job or a remote friendly job, you will see the families make the hard choice that, okay, this parent will stop work while this child goes through therapy, or this caregiver of mine, aunt, uncle, whatever relative, is going to be the one standing in the gap while I'm in the hospital, taking me to the appointments. I question families about this all the time. And I get answers that vary from, oh, I have a great workplace, they understand, to dynamics of people leaving their jobs to care for their child, using money that is supposed to be savings, investment money, if they have it, into helping their child. I've heard extremes like, oh, we took a second mortgage out on our house to help care for our child. And so there are several impacts to the socioeconomic fabric of a person's life, regardless of their pay grade. Even a middle class person, it's a big ask. It's a big ask for anybody. And so, yeah, thank you for that question.
yeah, well, thank you for raising those points because you don't hear them raised often enough, I think, in these conversations. Again, we get back to the manufacturers and the health systems, but lose sight of some of the out-of-pocket costs that are not necessarily out-of-pocket healthcare costs, but life costs. Stacey,
Yeah,
did
and
you jump
I
in
just
and
wanted to add, this comes up a lot in cancer treatment, is this concept of financial toxicity and also around the time burden of obtaining care, and this recognition that families and the person undergoing the treatment are sacrificing a lot of things in addition to the cost of the treatment itself. So I think it is a very important thing to bring up, and to recognize the payment systems don't cover many of those other ancillary costs. So like, you go somewhere, you need to stay in a hotel for a long time or rent a place to get the treatment at the center that you want to be treated in. A lot of times those things aren't picked up. So it's a huge missed opportunity to help people to be able to access the care. I also was reflecting during those comments about some of the questions I had during, when CAR T was first being rolled out, and, there were these single case agreements being negotiated, even for commercially insured people. And I said, okay, well, how much does the person have to pay? Like, nobody seemed to be able to answer that question, and asking clinicians, do you know what happened to the person that you treated? And they're like, well, I think they were just grateful to be alive. And it's like, well, I'm sure they were, but, if they were left in financial ruin because their part of the bill wasn't something that was explicitly considered, that's a real problem. So I think it all comes back to not really having a system built for this type of complex treatment, and especially how this looks worse once we get away from commercial health plans.
And can I echo that last point, Stacey? Desperation. And it doesn't matter what the disease we're talking about, there's this desperation with families to do everything, especially with cancer. And it causes a lot of this so-called financial toxicity because of that's what's driving them, the desperation.
Well, it's a good segue. We only have 2 minutes, so you get a maximum of 30 seconds each for the last question, which is a hard one, which is, given everything we've discussed today, could you give policymakers one piece of advice to improve affordability and access for cell and gene therapies? Titalope, can I come back to you?
I will say, please continue to put the lived experience, the patient and family voice into your conversations, which might mean you need those town halls or special listening sessions, because I really want to make sure that's not lost. In regards to bringing down the cost, I did have this maybe naive view of, well, this is, Tesla 1 or iPhone 1 stage, and iPhone 13 and 20 and Android 25 is going to be cheaper. And so this is the elite stage. Only certain people will get access, but I'm praying for that day where more people will get access. And so I don't know how naive that is. And yeah, so I'm looking to you guys for the answers.
All right, Jared, I'm going to say 20 seconds.
Yeah, so got to get away from the fragmentation, size, uniform approach, coalescing data, spreading risk. All of these things are paramount here. And so I think there is an intersection in our payer models, commercial, government, that we're not even contemplating yet. I think Medicaid is a nice start, what they're doing, but it's nowhere near where it needs to be. And I think there's a lot of discussion needed how we get that uniform approach. And I think it is merging commercial markets into something broader and something bigger.
Aaron?
I would suggest that President Kamala Harris expand current CMS negotiation to encompass cell and gene therapies so that we can have a public and multi-stakeholder conversation about what these things should actually cost.
Stacey, you get the last word.
Medicare Part CGT.
Well done. Okay. Well, I want to thank all four of you. I think we should reconvene in a year or two to figure out where the heck we're at, because there are some major challenges, I think, in this area that you've all described quite well today. But I do want to thank you for this great conversation. And to our audience out there, thanks for joining us, and have a great afternoon.